Bienvenidos a Hemisférix, el podcast de fisioterapia y neurorehabilitación, presentado por Javier Sánchez Aguilar.
I'm with Rini Varghese, physical therapist from India, PhD from the University of Southern California, where her dissertation work investigated arm use and non-use, specifically bimanual arm use and motor control and ipsilesional deficits post-stroke. She has published several articles on these topics with her doctoral advisor, Carolee Winstein. She is currently a postdoctoral research fellow with Amy Bastian at the Hopkins University and the Kennedy Krieger Institute. For me, it's my pleasure that you are here at Hemisférix today, Rini. I have been reading your papers and they are very interesting. That's where my interest in interview you comes from. So hello, Rini, welcome to Hemisférix. Nice to meet you.
Nice to meet you too, Javier. Thank you for having me.
The topic of this interview is really interesting and really difficult to establish several key factors or key ideas. The upper limb rehabilitation is quite difficult. Every clinician and researchers know that. And this interview is aimed at learning about the research on the upper limb in which Rini has participated. And we are going to ask her about several topics like the upper limb rehabilitation in general, first of all. Then the learn on use is a very actual, but not as actual that we know. This concept has several research before. We are going to talk about the ipsilesional upper limb and also bimanual motor performance. So I think Rini is going to talk about several concepts that are really powerful, really actual. So we are going to learn a lot about upper limb neurorehabilitation. So Rini, in these interviews, we always start by getting to know the guest a little more. So who is Rini Varghese? Why is she a physiotherapist, and what brought her to investigate this problem, this post-stroke upper limb?
Yeah, sure. I was trained primarily as a physiotherapist in India, and during my clinical rotations, one of the problems that I'd observed was that our caseloads were quite large, and we had limited amount of time to deliver therapy. And the therapy that we were delivering was somewhat tailored to each patient, but at the same time, with the restrictions in time, you had to be quick about assessing a patient and knowing what the problems were or impairments were, and then devising clever ways to try to get the patient to do, use their arm or go home and work on their strength or work on their dexterity. That challenge, the challenge of time, and the challenge with tailoring PT for each participant made me realize that we needed more. We needed to understand what made each participant, each patient different, and their condition different, and their impairments different. And part of that is a story for neuroscience. Understanding where a stroke affects the brain is important to knowing what kind of deficits to expect. And so part of the answers I was looking for were in the textbooks, out of which we learned. But part of that was not in the textbooks. Part of it was still a mystery. It was not clear why we did certain things and why certain things work for certain people. And so that is what took me to the research route. I realized that I needed more training in doing research and understanding patients, but my clinical brain was always active. I really wanted to understand the case of stroke as it applies in the clinic, which is a really different problem than when you're studying it in the lab. So, but you still need the skills in the lab. So I took my clinical background and I went into a master's program where I got trained in doing research, the basics of doing research and asking a question designing an experiment. And after that, I did my PhD at the University of Southern California, where I wanted to specifically focus on the problem of strokes. My master's was not stroke-related work, but it still gave me some research tools that I thought were useful. And then in the PhD, I used those tools to investigate stroke, the problem of stroke, and human stroke and motor impairments. So that's about who I am. I'm a clinician at the heart, but I have been trained to be a researcher, and that's where I'm continuing my work now.
Do you think it's important to become firstly clinic and therefore and after the researcher? Because there are several discussions about this. You have to be first clinician and then research, because if you don't know any patient, you cannot apply the research to the clinical practice. So what do you think about have some experience in the clinical practice and then introduce himself to research?
I think that is a restricted way of thinking. I think we should break out of that. Yes, as clinicians, we'll know the problems before we know the solutions. But I think it's the same with programs being more interdisciplinary now, with PhD programs especially being interdisciplinary. I think an engineer could understand problems if they collaborated with a clinician. So I think first, it depends on what type of work you're interested in doing. If you want to do something translational into the clinic, it's always good to collaborate with a clinician. And you can not only collaborate with the clinician, you can learn from them. Similarly, clinicians can collaborate with researchers and learn from them. And I think that it doesn't matter what your past experience is. It matters to some extent, but if you wanted to, you should and be willing to learn to switch your way of thinking to try and understand how to apply solutions. And then there are others who may not be necessarily interested in taking these tools to the clinic. They may just be interested in exploring for curiosity, which is good also.
Yeah, I agree with you. And why did you become interested in neurorehabilitation? It becomes from the clinic, from the university. You have a good relationship with the professors and with the way of teaching. Why did you become interested in neurorehabilitation?
Yeah, like I said, so my clinical background was varied. During my clinical rotations, I had rotations in orthopedics and neurology. The problems that interested me most were the problems of the brain. They were neurological problems, particularly stroke. And so it was instant. The love with the brain and how brain dysfunction can cause serious impairments in everyday life was a really interesting problem, and a problem that I thought was not straightforward. So I think a part of me was just curious. So I took on the role of understanding the neuroscience and the neurology behind these problems. I think that is how my interest in neurorehabilitation came to be. And along the way, I found excellent mentors and people who helped me even further deepen that curiosity. So I think that I'm thankful for colleagues and mentors who actually helped me find solutions as I was digging through this problem.
I also have that interest in the brain, and I have to tell you that my first patient was an alien hand patient with apraxia, with a corticobasal degeneration. And that fascinated me as much as it scared me. And then I got love with the neurorehabilitation. And yeah, many clinicians say that the love for the brain, then comes the love for the patient and to recovering. And I think the person who loves neurorehabilitation has several grade of patients that many other clinics doesn't have. I know the sports physiotherapists that has to be so faster with the ankle sprains, with the rehabilitation, always is fast, but in neurorehabilitation, always the process is very slow. So I think the people who love neurorehabilitation has several personality features.
Yeah, I think you're right. I think the personality is to delay gratification because you don't really see instant results. You see results over time, and that's, I think that has helped set expectations correct for research also, because research is not instant gratification either. So yeah, you're right.
We move to the first topic about the upper limb rehabilitation. When we read about upper limb rehabilitation, and we even work in the clinic with these neurological patients, we always have a feeling of dissatisfaction. Like we don't quite understand why it is so difficult to recover this upper limb. Obviously, most dissatisfaction with most severe patients. Have you had this feeling too? What are your impressions on post-stroke general upper limb rehabilitation? You comment before that in the school, in the physical therapist degree, you have this sensation, this impression. But what do you think about this? About the upper limb rehabilitation in general?
Yeah, I think that the case for upper limb rehabilitation is significant because of the variety of things we do with the upper limbs. I think the most interesting part about the upper limb and rehabilitation applied to the upper limb is because the upper limb is so diverse and so redundant. You can do
complex
hundreds of things and complex things with your arms and your hands, and so which is why when in the case of severe stroke, where there's a large amount of damage to the descending pathways, and impairments that leave you not to be able to use your arm or your hand, are the most severe ones, are the ones that we find fascinating in a way, that people are not able to go back to their function. It's both tragic, but also a problem for research and for the science to discover. So I think in general, from a clinical perspective, upper limb rehabilitation is complex because of how much we do with the upper extremity. And from a research view, it's vastly understudied. So I think that understanding both aspects, the clinical aspect of how much you can do with the upper limbs, and then trying to make some sense of it from a research perspective are useful.
In 2018, you published, together with Carolee Winstein, an article about the past, the present, and the future of post-stroke upper limb rehabilitation. In the article, you talk about how in the past decade, studies were carried out, such as Excite trial, Albert, but the scientific basis was, you told it, immature. The scientific basis was immature, and it could be seen that not everything were a question of dose, that we have to go beyond the dose. You consider past what for some people is future. I have to tell you that by my experience, because they are not up to date with the evidence. So what makes the difference between the past, the present, and the future in the upper limb rehabilitation? With what are the key paradigms or the key concepts that separate the past, the present, and the future?
Right. I think that this is an excellent point. So I do appreciate the fact that what we considered in that article as the past was related to findings of the Excite trial, which were focused on specifically constraint-induced movement therapy and the effective dose. And that we know that even in current investigations, it's well known that humans do not receive even nearly the dose of therapy that they should be receiving. So in a way, talking about that in the past may have some problems because really, even in the past, as it were, we did not deliver the dose that we're talking about that is effective for rehabilitation. So the question about dose is one that requires more research. But it's not simply the dose element that is the thing of the past, but the thing of the past is specifically with constraint-induced therapy, the idea that you can restrict one limb entirely and with some shaping of the non-paretic limb, achieve functional recovery. That's a term we can define later. But with the non-paretic limb, what was important to notice was that the dosage of therapy with the shaping exercises were really, really large. They were repeated a lot of times to be able to affect that. And number two, we talked about this transfer package, which in follow-up studies to the Excite trial were found that it was not simply the dosing and repetition in the clinic, it was what they took home with them and contextualized in their real world. So I guess this is bringing the point of use in the real world. When you go out of the clinic, and we all know that the patient cannot be in the clinic, they have to go take and generalize what they've learned here to their real world, which is the world that they live in, with their grandchildren, with their children, with their spouses, with their people of interest to them. They interact, they have to do self-care activities. The things that they do with that limb is what informs their ability to keep using it. And this sort of triggers a cycle of reinforcement that continued success by continual use of that limb is what causes this virtuous cycle of use. And so that's the thing for the future. So if I wanted to connect the past, and one element of that past is dosing, which we still don't know the exact parameters for, I would say the other thing we know from that past is to modify what we existingly know about constraint-induced therapy into understanding shaping and understanding how to generalize that shaping activity from the clinic into the real world and understanding real world behaviors. So yeah, that I think is the future, to best know the parameters for what might generalize, how people generalize, how much they use their limbs outside in the world.
You speak about the present in terms of overcoming the concept of dose and going further with interventions that you said that are based on neural networks. That is quite interesting for me. To what extent does taking these neural networks into account help us in rehabilitation? What interventions are supposed to be currently based on these neural networks paradigms? What do you mean by neural networks?
I wonder if you're asking about the detour networks that we referred to.
Detour, these circuits.
Yeah, so the general idea here is that I think the distinction comes from the fact that as clinicians, we talk about functional recovery in the clinic. And if you ask neurologists, they'll talk about recovery in the brain. And in the brain, recovery often involves generating tissue, which we know is not a possibility in the brain. So we're not able to generate new tissue in the brain. At least that's what we know. We are able to generate synapses around the injured area. So when we think about this neurophysiologically, we argue for this idea, which I should credit to the authors that actually wrote about it. The ideas of detour networks was, I will give you the name in a second, but the idea of detour network was that we don't have to rely on the injured tissue, but the ability of the brain to make connections around that tissue. And it's not possible to make these connections very far off, but they have been the basis for how we understand these compensatory behaviors might arise, that people may show, may take advantage of this type of detouring around the tissue to be able to generate useful behaviors. Sometimes those are not always useful behaviors. They're compensatory behaviors and maladaptive behaviors. But I think we're all trying to figure out what types of exercises and activities will engage those detour circuits. One argument is bilateral activities that involve both hands can help take advantage of these detour circuits, perhaps transcallosally. Mm-hmm. The other idea is in really severe patients using training of the quote unquote good limb or the ipsilesional limb. That may help trigger ipsilateral pathways and other callosal influences on the ipsilateral pathways, particularly reticulospinal tracts, to help improve behaviors, improve paretic limb behavior. So we don't have what's imagined in the extreme. We don't have the pyramidal tracts anymore. So there are other tracts like the ipsilateral tracts, reticulospinal, reticulopropriospinal tracts that can help support these motor behaviors. That's the general argument with the detour circuits.
Mm-hmm. As clinicians, we try to understand that our exercises have consequences on these circuits, but we don't know. We do not know what is happening in the brain. I don't know if it is part of the future. In the future, maybe we are going to talk about the pathways. No, I want to recover the reticulospinal tract to influence to the upper limb. I don't know. Many clinicians talk about the therapy like this. It's very ambitious, I think. We are not at that point. But how can we approach that understanding of the brain in a relational way of the research to the clinical practice? How can we approach that?
Yeah, I think this is an interesting question because I don't think we ever want to approach it that way. I don't think we ever want to say that, oh, the patient's coming in, we're going to train him on activities that are going to engage his reticulospinal pathway. Because frankly, I don't think the patient cares. I think the patient cares about doing the same thing. Exactly. He wants to walk. He wants to be able to hold his coffee cup in the morning the way
but
he
maybe
used to.
The clinician has the responsibility to know what he's doing with the patient.
Yes.
And
yes.
maybe the discourse of the therapist is obviously based on the goals of the patient and has a good language, appropriate language with the patient, but maybe in the mind of the therapist has to be functioning this relationship between the neural networks and the exercise that he or she is doing.
I agree. I think part of that is training. So in school, I think training, engaging evidence in the later years of physiotherapy programs, I think are a way to do that, is to help students understand why we're doing certain things. And the other way to think about this is, the other way to think about problems in the clinic is good assessment tools. I'm a strong believer that if clinicians get the right tools to assess problems in their patient, some problems you can observe and clinically verify. Some others you need some fine tools to be able to tell you, this is a problem with the cerebellum. If I notice dysdiadochokinesia, that is a problem with the cerebellum. Things like that, I think with training and with appropriate assessment tools and repeated assessments, we can get to this type of problem. And then the clinician in the back of their mind can think, okay, I'm seeing a patient who has tremors, ataxia, these problems. This likely signals a problem with cerebellum. The best tools I have to get to that problem are these. These are the set of activities and exercises that I can use. So I think that you're right. In the back of the mind of a clinician, they should have an idea for what the problems are and how to approach those problems. But to the patient side of things, I think the patient needs to make sure that their goals are communicated to the clinician, and the clinician should be focused on helping the patient achieve those goals. So it's a two-way street.
It's really hard to know some therapies that has this mindset of neural networks paradigm to explain the therapy. I think the status quo of the explanation of the rehabilitation is mainly biomechanical. And that's right, I use it. I use several treatments that are really explain about this biomechanical approach, but maybe we have to move little by little to this nervous system explanation. But it's hard. Yeah, I think it's a very hard problem that we have to solve. And we need person like you to translate the research to the clinical practice and to make some messages, short messages that we can apply in the rehabilitation. One of them is the how we manage the ipsilesional side that we maybe forget from the rehabilitation. So next we will talking about this problem, but I want to ask you, what do you consider the status quo in upper limb rehabilitation? What do you think is the mostly applied upper limb rehabilitation in most clinic of the world? What do you think?
Yeah, it's a very interesting question. Also speaks to this idea of what is convention. What do you exactly apply? What is conventional therapy in stroke?
Yeah.
From where I come from India, one of the predominant practices was a therapy known as BOBATH. Are you familiar with BOBATH?
Yeah, neurodevelopmental therapy,
exactly.
NDT. BOBATH.
Exactly. NDT and BOBATH is the predominant way of approaching. And of course, now you can see it differs across the geography. So I think everywhere in the world, something else has been taught and something else has been practiced. But BOBATH, or the principle of neurodevelopmental therapy, was the one that I was most familiar with. Here, of course, in the US, I think that conventional practice has to do more with setting patient goals and then helping them achieve those goals through task-specific practice, and that in itself is a little vague in definition. But these status quo techniques, status quo applications, don't always work, and it's not clear who they work for. So I think what we call status quo may be modified slightly bit and becomes a question for research. Does that make sense? It's not just convention anymore. It's convention modified, which is a question for research and then seeing whether that applies or not. So it would be wrong. It would not be appropriate to say that there is one convention. It also wouldn't be appropriate to say that whatever we define as convention remains convention. It could become a research question if we just modify it slightly.
Mm-hmm. There is a clinical stereotype that we hear here in Europe, and that is that in the US therapists do not touch patients with this conventional therapy that is task-oriented therapy, for example. And this is so visible in CI therapy when we set up several tasks with the shaping, with the task practice, also the transfer package, and yes, there is this clinical stereotype. It is so. What do you think? What do you have experience?
I have not practiced in the US, so I am unable to comment on that. But my understanding and impression has been that, at least in the case of stroke, it is or neurological disorders in general, one should consider what it is that we're training. And if we are truly training the brain and its amazing adaptive ability, then you don't exactly always need to touch a patient. And by touch, I truly mean use of electrotherapeutic modalities, which I think was very predominant in India too. So there may be some instances where certain electrotherapeutic modalities, IFT, shockwave diathermy, those kinds of technologies, they can be used to manage pain on some level. But ultimately what we think, and is I think the predominant school of thinking, at least from my experience in the US, is that we're training the brain, and the brain learns and the brain adapts. And so a person should, if you structured practice and if you structured exercise routines in a way to maximize the brain's ability to learn, then you will have accomplished its ability to repair and its ability to, return to function, more than it is to necessarily engage in overt forms of therapy like massage or electrotherapeutic modalities. So I think it's definitely away from those things and more towards, taking advantage of the brain's ability to learn and principles of learning.
Mm-hmm. Yeah. There is a concept that is very interesting. Is the one of the most referenced concept in the literature, that is learn and use. It has been a concept that has grown within the CI therapy. It's an essential concept in CI therapy. I'm going to ask you, why is the concept of learned use an essential concept in neuroscience and then in neurorehabilitation? Why a therapist or a researcher has to know about this concept of learn and use?
Yeah, it's a very interesting concept clinically, and as you mentioned, the idea informs CI therapy. The idea came from studies of monkeys, deafferented monkeys, whose sensory input from one limb was unavailable to them, and that led them to not use that limb. So much so that they alienated the limb, that they started to self-mutilate and cause damage to that limb. That is how they were not aware of that limb. Now, the reason why this became an informative thing for CI therapy was to get at the point that when you have such an injury where one limb is restricted, you tend to use the other limb a lot. The other way that this has developed over the years is through the idea that non-use can be a problem in the clinic, because patients may have sufficient capacity to use their limb, but have learned not to use them over time, probably due to reinforcement of certain signals. So getting negative reinforcement by using their paretic limb, and positive reinforcement by using their good ipsilesional limb. So it's important in the clinic because the value of providing therapy may be limited if we do not identify cases where there may be learned non-use of the limb.
There is an implicit assumption behind current approaches or conventional therapy that the improved motor capability or capacity after intervention will automatically promote the spontaneous functional use of the paretic hand. And in an article, I don't remember what, you say some data about the 52% of patients didn't incorporate the paretic hand in daily activities, or even in those patients with full motor recovery, 27% reported reduced hand use in daily activities. So it seems that the use of the upper limb doesn't depend only on motor capacity. And that's a shock for many professionals that has that implicit assumption, as I said. So if non-use doesn't depend only on motor capacity, what other factors influence it? How can we understand this learn and use on a scientific basis?
Yeah, we in a separate study, we studied this phenomenon of learn non-use using an experimental approach, a task known as the actual amount of use test. And I will describe that test in a second. But what we found were the other factors other than capacity that seemed to tell us something about use behaviors were related to motivation and arousal. And arousal was a term we use for general attention, not to any specific field, but overall attention to the task, as well as motivation, which we gathered that from a test called the confidence in arm and hand movements questionnaire. The actual amount of use test, which was the test that we used to assess use, is quite interesting. The modification of that test is what we used, and the modified test has two components. There is a forced use component and a spontaneous use component. But what's really cool about the actual amount of use test is that participants who come into the research study are unaware that they're being tested. They're debriefed at the end. So
they're
we
blind.
use yes, they're blind, exactly. They're unaware that things are happening. Use a video camera, and we incorporate a set of 14 tasks into a narrative that suits them. So they come in and we give them their consent forms, and we ask them to sign it, and then we ask them to handle an album that we give them, and they'll tell them to just peruse it, and so on and so forth. So there are a number of tasks that they do. They don't know that they're being tested, so they spontaneously use the arm that they would use to perform this task. And so that's the first batch of 14 that we do in the spontaneous component. We then have them do the forced component. We ask them explicitly to use their predicate limb to do these tasks. And that gives us an indication for their capacity.
You then evaluate the difference between the spontaneous and the forced. And the
forced to get a sense for the degree of non-use. So learn non-use, in the way we define it, is despite having the capacity to do a task, that you don't spontaneously choose your predicate limb to do it. And so the difference is how we evaluated non-use in that study. And what we found was the thing that influences it, was associated with it, were factors related to motivation, as we measured in the self-efficacy questionnaire, the CHM, as well as arousal. Those were the other things that we found were useful. There are some tasks in the AUT that are bilateral in nature. So clearly, when you have two hands that need to be used, asking someone to just use the predicate hand is also not necessarily optimal. So I evaluated the spontaneous bimanual use in one of my studies. And what we found there was, in using both hands, the other thing that really matters is the task that they're doing and the side of creases. So if you needed to use your left hand for something that required a stabilizing component and your left hand was predicate, you would tend to use it more, as we would expect. So those kinds of bimanual use differences were parsed out in one of the other studies that we did, and their side of lesion or the side of hemispheric damage seemed to be an important factor too.
I think it's very interesting that differentiation between the spontaneous and forced situation, because I know the motor activity log, this test that is specific for CI therapy, and they evaluate the confidence and the amount of use. But I think they don't differentiate between these two circumstances. Also, the test is so useful, but with this test, I think by clinical, not the quantification that is important, but in a clinical point of view, this is really, really interesting to evaluate, because we know in clinic that there are patients that do not have that initiative or initiation of the activity, the spontaneous use, and we have to force. And there are patients that are really motivated. And yeah, I recognize as a clinician that factors, the self-efficacy, the attention, the arousal. And what about this these features of neglect or apraxia. We know that patients with this problem automatically have the learn on use, but what do you think about that?
Yeah, so in the study that I was referencing earlier, it's the Bucksbaum study that we did, published in 2019, I believe. That study, we assessed apraxia also in those patients, and it did not seem to correlate with our measure of non-use. That could simply be because they were not as severely affected. Their apraxia was not as severe. So we wondered if we included a group of patients that had more severe apraxia, would we see these effects to start showing up? But that is the extent. I would hypothesize that you would see a relationship with apraxia and with neglect. Again, with neglect, as I said, we used a spatial measure for attention, and we did not see any differences between attention to a specific side, which we would if people had neglect. We would see that show up in that type of a test, and then we would see a relationship there. But it was more general attention to the environment. That's how we observed it. Once again, neglect wasn't severe in these patients. We looked at a group of moderate to mild motor impairment patients, also patients who were not as severe. So part of us wondered if we just did include severe patients, maybe we'd see that show up. But that is the evidence we have so far, is that apraxia and neglect did not seem to correlate in our little data set. But it might in more severe participants, but we haven't tested that yet.
Many patients tell us that that patient over there moves his hand less than me, but I see him opening doors and using his hand to eat, to manipulate some objects in a bimanual way, but I don't use my hand. I can't. So many patients tell us why this is happening to me, and sometimes we don't know how to answer this question to them. But with this information that you have given us, we have more idea about this issue, and that's right. Many patients have less than 20 points in Frugal measure, but has a more participation in the daily activities that maybe a patient with more than 45 points. That is a good cutoff for Frugal measure for motor capacity or motor control. So this is very interesting, the relationship between the behavior of the patient and the explanation in a neural basis. Yeah,
I think so. And there is always the differentiation between proximal control and distal control. So certain participants of certain patients were able to do more with their hand, even though their posture is somewhat inoptimal. Even so, if they're able to use their hands, often we see them making more progress, because you can only do so much by reaching. The next thing is to manipulate with your hands. And so we see a little more with patients who are able to do that than patients who have both postural problems as well as problems in dexterity. So that's, I think, a discussion for another day.
And do you think that this learn on use can be overcome in the acute phase, or it does depend on the therapy that we apply in this acute phase?
Yeah, I think that generally speaking, therapy can be most effective if it were delivered earlier, sooner after the stroke. And so emphasizing early physical therapy and large doses of early physical therapy is a good thing. Where that window is when we start to move from acute into subacute into chronic, where that window is not clear. Does that also mean that when you get into the chronic phase, you can't get reasonable functional improvements? I don't think that is true either. You can possibly get reasonable functional improvements as you go on later, but early is best. If we can actually attack some of these problems very early, that's good. The other thing about learned non-use, and the reason why it's learned, is because it implies that there is certain learning over time after the stroke, when exposures of using the limb may have gotten negative reinforcement, and may have gotten negatively reinforced, and therefore the non-use is a learned phenomenon rather than being that way from the beginning. So identifying something like that early on may be useful towards arresting its development over time. I think that keeping those things in mind is a good thing. That also tells us something about how we might structure therapy early on. We can't necessarily limit failures, right? We cannot limit failures when people are trying to do them. But how we help the patient approach those failures, that may be the thing that we may need to do.
I agree with you. Yeah.
So
totally. Yeah. Let's move on the next topic. Okay. That is the ipsilesional upper limb. I think this is a very interesting topic. I have learned a lot with your research because regarding the ipsilesional side, it seems that we have stopped using the terms unaffected side, definitely, apparently, and we use the less affected side, no? For example. And regardless of phenotypes such as ataxia or apraxia, what do you mean by the less affected side? What is the relevance of the ipsilesional upper limb in a neuroscience vision, not in the practical vision, but in the neuroscience point of view?
Yeah. So for a long time, we thought the stroke affects one side, and then the other side is perfectly normal, is good. But that turns out not to be the case. It turns out that you have measurable deficits in that limb. They're not as significant, so they don't show up in everyday function, but they are there. And what that means is you have a limb that's affected and a limb that's not quite as good as it used to be at doing things. And that leaves you with a problem that is bilateral. So you start to, as a therapist, I think it's important to keep in mind that you are not dealing with an extremity that you can easily compare to. That's not the optimal way for that extremity to be operating. From a neuroscience perspective, it's fascinating to see that the deficits that you see in the ipsilesional limb reflect the damage of that specific side. So that if your left limb was the unaffected limb, you would see different set of deficits. And if your right limb was the unaffected limb, you would see a different side of deficits. So the less affected limb is an amazing window into how the brain is organized. It tells you something about how the brain is organized and the control of these movements.
Patients, when we tell the patients this explanation, the patients tell us that, oh, I have a double problem. Another problem for me. Oh, my entire body is affected. It's not about that. We have to explain in a better way what is happening in the brain. Maybe we can explain what deficits can the ipsilesional side present. What deficits can be the problems? Maybe the patient do not aware of these deficits, but there are in several movements or in several situations, like the mirror movements, radiations, and so on. So what kind of deficits can the ipsilesional side present?
Right. So what we found and this is based on a long line of work by Bob Sainberg's group at Penn State University, who studied ipsilesional deficits, and a really old study that was done in our lab, in the lab of Dr. Carolee Winstein. And that seemed to suggest that people who have left hemisphere strokes with their non-paretic or less affected left hand, they had problems scaling velocity. So if you gave them a speed-based task, you would expect them to be slower than than they should be on that task if you scaled. So that was a problem very specific to the left hemisphere stroke. The right hemisphere stroke, it was a bit of a mixed bag. But what you saw in them was the inability to correct movements as you would. So when you make a movement, you rely on some online corrections, some corrections to the movement itself. And they were unable to make those kinds of corrections. So they had slightly separate problems. Are these problems relevant to the patient? They may or may not be, which is why I think your point about, which is why I think your point about telling the patient that, oh, you have more problems is not the best approach. I think you need to be tactful about what kind of problems. And I think the best way to approach that may be to tell them that let's test your good limb. And so if we're seeing deficits of this nature, that says something about how your paretic limb might be behaving as well. So we're only assessing this so that we can get a sense for the kind of deficits we should expect in your paretic limb. And it's much more testable than the paretic limb when it comes to these sensitive measurements. So all in all, I think that ipsilesional deficits are important to address in bilateral context when you're introducing exercises like that, but they may not always rise up to clinical level of significance for people too. And that is a completely different case if you are severely affected. If you have a stroke and severe impairments, that non-paretic, less affected limb is your go-to limb, is the limb that you rely on heavily. Now, if it has some deficits, even if they're subtle, they may interfere with your ability to function. So thinking about ipsilesional deficits from that perspective is helpful, that if you're very severe and you're relying on that left hand now to do things, we need to understand and make sure that the left hand can do everything it needs to do to the fullest extent.
The audience has probably noticed a break in the interview. That's because Rini had to cut it. We apologize. Let's pick up where we left off. We were talking about the ipsilesional side after brain injury, and you were talking about, Rini, the different deficits or impairments that can be described on that ipsilesional side. So could you come back on that topic? Can you remind us what deficits or impairments we can observe on the ipsilesional side after a brain injury or a stroke?
Right. Right. So for a long time, we thought that a stroke affects the contralational side of the body. So the opposite side to which there was a brain injury. But at least since the late 90s, we've had evidence of subtle deficits in the quote unquote good limb. And it's often one that's been neglected in therapy. We don't pay attention to this other limb. And the nature of deficits over time we've found is influenced by the side to which the stroke affected. So a left hemisphere stroke has the deficits that you observe on the left hand. Someone who has a left hemisphere stroke, it has problems with scaling and speed, such as would do with predictive mechanisms of control. Conversely, people who have a right hemisphere stroke and a right limb, that's a little more of a mixed bag, but they show deficits in feedback control. So they're slower because they're not able to incorporate feedback very well to make their movements more accurate. So these are some differences that we've known about these two groups. Are these deficits severe enough to be functionally relevant? Probably not. For a lot of the mild to moderate for patients, people who have mild to moderate impairments in their paretic limb, they show, in one of our papers, we show that even in those ranges, you can observe these deficits in speed, for example, in left hemisphere stroke, but not in right hemisphere stroke. But they may not necessarily be functionally limiting. In the patient group that this really matters are people who have very severe deficits in their paretic limb, because not only now do they have a very paretic limb that they potentially cannot use for functional activities, but but they also have a non-paretic or less affected limb, which has these subtle deficits that can get in the way of getting things done faster or more accurately. So, so it's from that perspective, we start to think about ipsilesional deficits more seriously. How can we now do something about these types of deficits in therapy? And that's where we're proposing some solutions. So for example, one of the things you can do in therapy is design tailored rehabilitation to that limb, to the ipsilesional limb. And this is the work that's being done by Bob Sainberg and colleagues at Penn State University. And they have a collaboration with USC, where I used to be, to use this type of a therapy, ipsilesional therapy, in very severe patients whose Fugl-Myers are less than 20, less than 15. That's one solution. Another solution is engaging patients in bilateral activities, which inherently take into account both hands.
But there is some controversy, I think, no? In one article I read that there is some controversy with this bimanual training or bilateral training, sorry.
Yeah, the controversy, it seems to be coming from a neuroscience principle perspective. I think what kind of bilateral therapy do you do with patients is the question. The one that has the most established literature is known as backtrack, or bilateral arm training with rhythmic auditory cueing. And the goal with such a task is to take advantage of inherent neural systems that make the limbs move together. So if you have someone do in-phase, anti-phase activities with both hands together, the paretic hand can be pulled in the direction of the non-paretic hand and get better as a result of it, as a result of this shift in neural activity. But is that type of an activity functional? Because we don't necessarily move our limbs like that in the real world. In the real world, when we do bimanual activities, we have a hand that stabilizes and a hand that manipulates, and we have our hands work in functional ways. So I think the controversy there may be with respect to the type of bimanual exercises to be used. One has evidence behind it, the auditory rhythmic cueing, where there's rhythm involved in movements of both arms. And another one, it's more functional activities, but we don't quite have a lot of solid evidence to support that type of bimanual exercise. So we're still figuring out parameters of who this will work for and in under what circumstances. So I think that's where that is.
Within your work about the deficits on the ipsilesional side, I categorize these deficits in three parts, I think. I want to know your opinion. One is the mirror movements or radiations. The second one is the reaction times impairments that you have mentioned before. And in one study, you study with the stand reaching task paradigm to talk about the performance production measures and performance outcome measures, no? And they are different, and I didn't know that. Can you speak about this stand reaching task paradigm and what relevance or implication does it have to clinical practice?
Sure. So the stand reaching task was a task that I developed as a master's student. And initially it was to gauge a multi-segment, multi-body, multiple segments in the body, how they contribute to doing this task. So what we had known, we still know about control of such muscles across the body is that before doing any reach, you activate postural muscles of your body to be able to keep yourself stable so that the reach does not perturb you and you don't fall. The interesting part about this task was that we were testing a group of older adults, not stroke participants, older adults who had practice, who were doing their conventional form of exercising. So we used to keep a log of how much exercise they were doing. But then a group that had a long duration of practice with a mind-body training exercise known as Tai Chi. Tai Chi is a little like yoga, but it requires a lot of poses that take you in and out of your limits of stability, and you can build in complexity with the different poses. And Tai Chi is a highly skilled form of exercise, but it has been taken into mainstream studios to train older adults on balance. So at the time, my advisor, who had done quite a bit of work on this task, her name is Dr. Christina Wichan. She'd done quite a bit of work in this area to show that individuals who had had training with Tai Chi showed superior performance in balance and stability, but dynamic and static balance. So that was an effective way. But what we wanted to build onto from there was how good were their arm control? Was there any benefit to doing postural exercises to indirectly for the arm? And what we found with that study was that indeed people who had this long-standing practice of Tai Chi had quicker reaction times and faster movement times. So they were overall very efficient at producing arm-reaching movements. And we hypothesized that may be because they're posturally stable, so they can, training your body as a whole had effects everywhere, including upper limb reaching movements. With that said, okay, so in that study, we defined, we were using an EMG system, a built-in EMG accelerometry system to get EMG data from the anterior deltoid in this reaching task. And we defined a set of measures. We called some of them performance outcome measures, like the reaction times and movement times, which was terminology that previous studies had used, and performance production measures. So these were measures of activation in the muscle. And if you think about it, the brain produces bursts of muscle activation. So the muscle activations result in the movement itself. So we're thinking about that as production measures. And the outcome of those measures is a speed and accuracy of movement. So we thought about them as performance outcome measures. This is how it was defined in the previous study. So we took that terminology and we sort of distributed our metrics in that way to talk about them.
Mm-hmm. Okay. Mirror movements seems to me very interesting, and there is an intervention that is called transcranial magnetic stimulation or transcranial direct current stimulation that his basis is the interhemispheric imbalance, and one might think an interhemispheric imbalance behind the mirror movements. So I want to ask you about the pathological basis of these mirror movements, also the other impairments about the ipsilesional side. What is the theoretical pathological basis of these mirror movements or quite of irradiation in the ipsilesional side?
So mirror movements, from a pathological perspective, it has been long known that when there is maximal or supramaximal activation of certain muscle groups, certain larger muscle groups, that cortically there is a signal that is sent across, and then you begin to see activation of the other limb too. Sometimes they're very subtle, don't result in movements, but you will observe, if you put in an EMG sensor, you will see activation of those large muscles. And it's also true for larger groups of muscles, more proximal larger groups of muscles. So the idea with mirror movements or motor irradiation is that the motor cortex, after sending a signal, a descending command to one limb, especially of supramaximal nature, for generating a supramaximal activation of certain postural large group muscles, is not, sometimes may not fully inhibit the signal that goes across to the other side, to the other cortex, to generate a muscle activation on that side as well, which is why TMS like technology that can quantify interhemispheric inhibition between the motor cortices can be useful in gauging how much crosstalk there is between the motor cortices. Whether that is in some way functionally useful, these mirror movements, it's not clear. It only seems it seems like it's an interference, in fact. So people have not thought about those things in shaping these sorts of physiological phenomena into valuable therapy. But one thing that I always wondered about was if that may be the basis for bilateral types of training that requires both limbs. So, you can maybe take advantage of something like that, but it's I think for question.
Yeah, it's true. When we make an effort, a supramaximal effort, another muscle are activated. But this question may seem silly, but what is the difference between these mirror movements and muscle synergies? Because synergies are also irradiation of muscular activity, but I don't know if these phenotypes are different, or the mirror movement is quite a type of synergy.
Yeah, they may not necessarily be different in terms of physiology, but I think that the cross-body effect that you're seeing with mirror movements may be the defining factor. I must comment here also, synergies are defined differently. In the clinical world, we talk about synergies as a negative thing. When we see it in stroke, especially, we see these synergistic patterns of muscle activation that we often think are causing postural control problems that we need to get work around. In the neurophysiological world, synergy has been defined in a number of different ways, but it still means a group of muscles working together. But they often reveal about the organizational patterns of the brain, of how these muscles are represented in the brain, and perhaps therefore work together. So muscles that are represented close to each other can often take on representation from each other and result in these kinds of synergies. So it's of purely academic value is what I'm saying in another field. Whereas in the PT clinic, we often talk about synergies as a pathological manifestation in stroke.
Mm-hmm. Can we say that the larger the lesion, the more ipsilateral or ipsilesional involvement, the severity of the damage of the injury is a prognostic factor of this ipsilesional impairment?
It is not clear. I think that if we're talking about the size of the lesion itself and
the size of the lesion, yes,
then it is not clear, because the size of the lesion, even with larger lesions, if you have more pyramidal tracts that are spared, you can still get paretic limb involvement. And then if the paretic limb is getting signal, you'd imagine that it's less or it's more open to inhibition from the other side. But what we do kind of know is that maybe it is very much correlated with the amount of descending control that still is there. So the pyramidal tracts. If you had a greater lesion that almost entirely takes down the pyramidal tracts, the descending corticospinal tract, then you would probably see more ipsilesional control come into play. And it also depends on where that might have been, because anything that's above the capsule, the ipsilateral tracts have not crossed. So you can imagine that there may be physiological differences there as well. So I'm not sure if there's much been done about the size of lesion and the location of the lesion, and its correlation with how much ipsilesional deficit, ipsilesional drag. We saw this entirely on a clinical level. We used a measure of severity on the contralesional arm and a measure of function time, like the Wolf Motor Function Test on the ipsilesional arm for dexterous tasks. And we saw a relationship there. So the worse you were clinically on the contralesional side, the more severe your impairments were on the ipsilesional side. So we saw it sort of clinical behaviorally. We did not we did not use any of the lesion metrics to look at the relationship.
Do you plan to carry out functional neuroimaging studies to evaluate these ipsilesional deficits to go beyond the clinical parameters?
Yeah, I think that there is work being done right now. It's not using functional neuroimaging, it's using diffusion imaging to look at existing tracts and any lesion overlap with tracts in the study that we've been doing in severe chronic stroke survivors with Penn State. The collaboration between USC and Penn State, so work's ongoing there, and they're using diffusion imaging. But I think that there are clever investigations of using functional neuroimaging to do this. Not maybe of the ipsilesional side, much of the contralesional side, but it's up and coming. We recently are looking to publish a very small study that we have done with functional neuroimaging on a very old MRI system from the constraint-induced movement therapy data set, so from the XSIDE data set, in a small group who were trained on precision versus power tasks, stroke survivors. And we observed some changes in laterality index, which is a measure of which motor cortex was more activated. We looked at different areas. We looked at the premotor cortex as well. And what we saw was the premotor cortex showed a lot more activation, suggesting that it may have to do that it upregulates the lesion side cortical circuits in order to do precision types of tasks in chronic stroke survivors. So that's fascinating. Still not a direct answer to your ipsilesional side question, but I think that that's a promising area of investigation.
Okay. So we are going to talk about now about the last topic, the bimanual capacity. I think bimanual performance or capacity is a very relevant topic. Those of us who dedicate to clinical practice tend to see how patients have many difficulties in bimanual activities. We see that these activities is the last part of the therapy, the final part of the therapy to integrate both hands. But maybe in part the patients aren't aware of this role of the body, of the upper limbs. The patient may become obsessed with the finger dexterity and may not realize the potential of these bimanual activities. It is a topic that I would like to talk about, especially because it seems key to me when in several articles you say that this bimanual performance doesn't depend only on motor capacity. And I remember a patient who had a Fugl-Meyer score below 45. The affected hand was the left one, and you could see him using his hand to peel a banana, for example, spontaneously. And you wonder why or how come this patient is able to do it, but not one with a less affected upper limb. No, it's quite a contradictory issue. So Rini, what do you think about that? What do you think therapists and patients see bimanual ability, and how can we explain that the motor ability is not enough to explain this bimanual performance?
Yeah, I agree. I think with a lot of therapy, our initial instinct, which is a reasonable one, is to think that there are things that the patient is able to do, and we have to rely on that ability to craft. Sometimes pushing patients outside of that comfort zone helps, and you observe this in their spontaneous behavior. It's like peeling the banana. If they wanted to, they could engage their hand, even if in a supportive role, they can engage that hand and actually get things done, get their everyday function done. But when they come to therapy, we all become obsessed with the paretic limb and retraining just the paretic limb. So I think that with that argument and with some of the data that we saw too, capacity alone did not define how people used their limbs. It was part of the story. It was a strong predictor of who was able to use the limb or not. But in addition to that, people had preconceived notions about how their limbs moved. It's my left limb. I never really used it that much, so I don't want to fret about that left limb or use it more. But in reality, they have the capacity and they can actually use it. So engaging patients in meaningful goals that they set for themselves by setting up an environment where they can express that, I think that should be the goal for therapy. Instead of sort of relegating ourselves to saying, well, he doesn't have a lot of capacity. That used to be his non-dominant arm, so I'm not going to worry about it. We're going to focus only on that, things like that. So I think that we can push that boundary and start to appear, like you said, instead of approaching bimanual therapy towards the end of therapy, where we sort of incorporate it from the very beginning, because we don't have to think about bimanual activities as compensatory. They can very well be coordinated brain activity that can actually help us get to those functional goals faster.
Mm-hmm. A physiotherapist friend of mine told me one day that as a teacher, he told his students one day to do activities with only one hand for every day, to the whole day. So that they would realize the relevance of bimanual ability, and that was a shock for them. And then this professor introduced the bimanual capacity and the different functional activities that can be achieved in a very early stage of the stroke, for example, with the hypotonia and flaccidity. But yeah, many patients with very few movements can be participating in several activities. There is a taxonomy published in an article in 2019 by Chambra, I think, that they speak about the primitive movements and the different movements or movement patterns like idle, that has a traduction in Spanish. I don't know how to translate to Spanish. I think it's quite at rest. The rest position of the arm, the reaching, the transport, the stabilization. There are several movements that can be achieved with bimanual performance and has not to be with the dexterity specifically. So it's quite interesting, this bimanual capacity.
Yeah, I think it's very interesting, and I think there is a multitude of different ways to structure exercises bimanually that don't have to necessarily involve dexterity.
Mm-hmm. And speaking about this bimanual performance, what about the effect of impairment or the effect of cytolesion or the effect of the task? Do these factors influence the bimanual performance?
Yes. So the study that we did, one of the factors that we found interacting with capacity was the task, and different tasks seem to be interacting with capacity for each of the lesion groups. So people who have a weaker left arm, they can use that left arm for stabilization type of activities, whereas people who have a weaker right arm can use that arm for manipulation activities, if given that they have sufficient capacity. So if they have sufficient capacity, the kinds of tasks you can actually get the paretic limb to do match their previous preference from before the stroke, which I think is a strong testament to how the brain is organized in controlling the left and right limb for certain activities, especially in right-handed individuals. This is in right-handed individuals. So yes, so the task matters in the type of bimanual use that you observe. In bilateral therapy, if you were to give people who have a left weak arm, if you want to start them off with activities, you probably have better luck at getting them to do stabilization type of activities than you would with people who have a left hemisphere stroke. That makes some sense.
Although we cannot say that the motor capacity explain all the bimanual performance, you say in an article that there is a cutoff point on the Krieger scale that allow us to define good bimanual performance. What is this cutoff point on the Krieger measure, and if this cutoff point can be useful for therapists to make an idea of the recovery of the patient?
Yeah, I think, okay, so I have to start this by saying that data set and the other data sets that we refer to there are a very small group of people, a very restricted sample of patients. They had mild to moderate impairments. They did not quite have very severe impairments. So we can't rely on that cutoff as being something that represents a wide cohort of stroke patients. But at the same time, the value that we found was 42, where this interaction seems to happen, the Fugl-Meyer motor, upper extremity Fugl-Meyer motor score of 42. There's nothing magical about that number. I think what it indicates is some medium amount of capacity where you can go either way, depending on how therapy is structured for you. So I think in maybe making clinical decisions based on that number is not a wise idea. But what I can suggest is somewhere around that cutoff point, you might engage participants from that point or even earlier than that point in bilateral types of movements. There, we also argue that there's nothing magical about that number, but it has been shown that there may be a threshold for capacity. Once you hit that threshold and you have trained somebody to use both hands, they will continue doing that. This is a theoretical model that was developed by one of my committee members, Dr. Nicholas Schweighofer, where they show that once you exceed this capacity, you can begin to get that virtuous use cycle, which we were talking to in the earlier part of this interview. To get people to use their limbs, it's always good if you have capacity that exceeds that threshold. And once you do, you want therapy to be such that you can engage participants in patients in doing bilateral activities, and that will stick. Then that's.
In an article, you talk about the dynamic dominance hypothesis. I don't know if you describe a lot this theory. Maybe in that article you couldn't because of the size of the number of words of the article. But I'm interested in that hypothesis, and I want to ask you, what does it consist of, and how does it help to understand this bimanual performance, the dynamic dominance hypothesis?
Sure. Yeah. So the dynamic dominance hypothesis was put forth by Bob Sainberg, Dr. Robert L. Sainberg. He's at Penn State University. We're collaborating with him for a larger project on the ipsilesional deficits in severe chronic stroke patients. So that's an ongoing clinical trial. But he put forth this hypothesis, I think 15, 20 years ago, and his laboratory has studied it in a number of different ways. But the hypothesis is this, that we've approached handedness or dominance as a sort of static thing, that you have a dominant limb and the other limb is non-dominant, or does the same things but less efficiently. So we've always thought of the right limb as being the dominant limb in right-handed people, and the left limb as being like a weak counterpart of the right limb. So it does what the right limb does, but poorly. The dynamic dominance hypothesis suggests that dominance is actually dynamic, in that the right limb is dominant for certain features of movement, and the left limb is dominant for certain other features of movement, which is why the interaction with task that we observed in the bimanual use study, where the left hand was really good at when was required to stabilize in the task.
The stabilization task.
It spontaneously chose that behavior. There's a previous study by Carla Stone, and Claudia Gonzalez. In that study, they very cleverly manipulated in the experiment which limb reaches and which limb stabilizes or stays in one place. And even though they gave the left limb opportunities to do a lot of fast reaching, the left limb continued instead to just hover as though wanting to stabilize in the movement. So the point here is that there are features of movement that the left limb is really good at, especially what Bob Steinberg calls impedance control, which helps it to assume the role of the stabilizer in bilateral movements. And then the right limb is really good at doing predictive sort of things and fast moving in those kinds of things. So to take advantage of this dynamic dominance, my argument in that paper was that bilateral activity should be structured in a way so that you can take advantage of it, so that the left limb can do what it's really good at doing, the right limb can do what it's really good at doing. That was sort of the basis for talking about it in that paper. But in general, it's a very interesting hypothesis, and it continues to be tested. It's still a hypothesis. So his group, other groups are continuing to test this idea that the left limb, which is under the control of the right hemisphere, is specialized, not just non-dominant.
This is why in therapy, we may not be so obsessed with the manipulative skills in the left hand, for example.
Yeah, precisely.
Mm-hmm. Okay. I remember Gilbert Hayden. Do you know it? Do you know him? The Gilbert Hayden? I think he's a researcher in Belgium. He studies a lot of sensitivity and the prediction of bimanual ability by the diagnosis and the sensitivity. And I want to ask you, do you know or do you think that sensitivity has a role in this bimanual performance? Because there are several patients that have a very good motor capacity with the hand and with the arm in global, but they express that they don't have the enough sensitivity or proprioception or diagnosis to develop this bimanual performance in the daily life. So
yes.
What do you think about that?
Yeah, I think that there's a very interesting concept. I don't think that we can sense if sensitivity means sensory sensitivity and the ability to actually use feedback, sensory feedback effectively. I think that is there is no doubt in my mind that a good sensory system where feedback can be sensitively used is definitely going to be helpful. So in a lot of bilateral activities and unilateral activities, we're constantly using feedback in the environment to improve on our movements. So if somebody has proprioceptive problems, which we know in stroke people can have problems in proprioception, then you might expect that their system is weaker at detecting errors. And so therapy, the motor side of therapy, can't be as useful if the sensory side of therapy is not as effective. So I'm not sure how much I know about sensitivity training of sensory modalities, but something like that could help facilitate motor activity. So it's not just capacity, but the ability to use sensory feedback effectively.
Mm-hmm. Okay. I want to bring to my podcast the Gilbert Hayden, and maybe I can ask him this question, and maybe we can complete all the cycle of the bimanual performance. Recently, you published a very interesting study about the corpus callosum microstructure and the relationship with the bimanual performance. perhaps many listeners are wondering what the corpus callosum has to do with this bimanual performance, or perhaps the explanation is that this corpus callosum connects both hemispheres. So you have studied this corpus callosum. So what could you tell us about its role in the bimanual performance? I know that there are different zones of connection of the corpus callosum with the premotor or prefrontal region that may explain the reason why several patients has problems with the self-initiate bimanual movements and so on.
Yeah, this is it's a very interesting study, again, preliminary in nature, and correlational, of course, as is with so many imaging studies. But the idea here, we know that there is transcallosal interaction. That is the basis for a lot of the movements we generate. Even unimanual movements, the other cortex needs to be inhibited before the unimanual movements can be done. So in bilateral movements, the communication between the hemispheres is very fascinating. It has so many parts to it, I'm sure, but the premise of this study was we wanted to understand how the different parts of the callosum, if they had any relationship with bimanual performance. And it's a correlational study, so we're not talking a lot about physiological mechanisms by which they're doing this, but we're saying that if after a stroke there's some impairment in the communication between hemispheres, we should observe that in function in some way. And a lot of the studies have done that, but have focused on unimanual behaviors. We focused on bimanual behaviors. And the other thing that a lot of studies have done is focused on the motor cortex, because the motor cortex is where a lot of the investigations tend to be with respect to stroke. But we hypothesized that we know other areas, supplementary motor area and premotor areas, are particularly involved in planning these types of movements. So when the hemispheres are talking about, also when you're preparing for bimanual actions, there is a lot of motor planning that goes on before that, and the plans need to be shared for each of the limbs. And that we thought that the anterior regions of the callosum, such as the portions that connect the prefrontal and premotor cortices and supplementary motor cortex, that the structure and integrity of those fibers there in the callosum may tell us something about bimanual performance. And we used a crude measure of performance, really. We used movement time for people who self-initiated this use. They decided to use both hands, and the patients who decided to use both hands, we looked at movement times in them, how long did they take to do that. And one of the hypotheses, one of the points that we discussed in the discussion there was that perhaps what we're seeing, the people who showed slower performance may have been the people who've had difficulty communicating the plan quickly enough, via those anterior fibers of the callosum. And there is a well-known, a really old but well-known study that shows that those fibers of the anterior callosum are responsible for sharing what they call efference copies, a direct route for efference copies, or copies of the command being sent to the other side. That in itself is a good basis for saying that it's possible that these sharing of plans through efference copies, if they're not fast enough or effective enough, that you'd start seeing delays behaviorally. That is really a stretch there, but that was the idea behind that analysis. And we did find not only the motor cortex, the callosal fibers that connect to the motor cortex to be correlated with behavior, but also prefrontal and premotor cortices, which we thought was valuable to share with the community.
This topic makes me think of the idea of a joint work between the physical therapy and neuropsychology, because my work as a physiotherapist is not enough in many occasions to facilitate the behavioral change in the patient. the motor change is important, but the most important thing is the behavioral change and the translation to the daily life. So I want to ask you about this joint work between physical therapy and neuropsychology in these topics, these issues, like the planification, the executive functions, and the involvement in the motor capacity.
Yeah, I think, I mean, it's a good way to put it that there's a war between these two fields. But what I really feel is going on is that each of them is finding their way towards the other. As physical therapists, our education is changing. For a long time, we thought it was all about the skeletal system and muscles, but we've navigated from there onto understanding brain and understanding control, and from there and understanding learning, because it's a complex world, and to be able to operate and adapt in that complex world, we're constantly adapting. Our brain is constantly adapting our movements. So went from a skeletal system to a system where we know we can learn new movements in new environments. And psychologists come from a different perspective. So these ideas of movement planning and cognitive strategies and control of that nature, I think that they have started to appreciate that there are biomechanical constraints on doing certain things, right? So I think that's where we come from too, is that you have the muscle length is only this much, the bone length is only this much, you can only go so far. So there are constraints in the system that you have to be aware of when you're thinking about these things, especially like abstract concepts of motor planning and cognitive strategies and so on. So I think that as we're getting more interdisciplinary, it'll start to look less like a war, but more like collaboration between our fields. And I think there is so much potential to learn from it. So my advisor always tells me, my doctoral advisor, she came from a psychology lab. At that time, physical therapists didn't have physical therapy type of labs to go to. So she trained under a psychologist in a psychology lab. And now I am privileged enough where my advisors have been PTs all throughout. So I think that our fields are all moving together, the fields of neuroscience, physical therapy, and psychology in interesting ways. So good future. It's a good future to look up to.
That's the consilience. It's a very beautiful term, the consilience between disciplines. Okay, Rini, to end the interview, I would like the audience to take away some practical tips or ideas, some key ideas that we have talked about regarding the type of rehabilitation of the upper limb, how to involve the ipsilesional side on therapy, how to encourage the use of bimanual activity, how to understand the learn on use concept, all these topics that we have talked about. So what take-home messages would you give us to bring to our clinical practice?
Yeah, I think the two main messages I want to convey are, one, be open to patient goals. I think patient goals, structuring therapy after patients' goals and the goals that they find meaningful is going to be the way to approach it. Every patient is different. Every patient their deficits are going to be different. The motor deficits, sensory deficits, everything's going to be different. But what you can orient therapy with good confidence, if you're doing so, is to take into account the patient's goals first, and then tailoring therapy based on those goals with existing deficits. The second important point I think here is to be cognizant that there are sensitive measures of deficits. So keeping a track over time of a patient's progress by using these measures is a great way to focus on, is a great way to see how well your therapy did, I suppose. Mm-hmm. So I think taking advantage of these sensitive measures that are available and not being afraid of sort of using new measures or, getting trained on using new measures, I think would be a great way. And if we actually keep these two things in mind, I think that all of these different problems related to non-use, related to ipsilesional deficits, they will fall in place with each patient. Each patient will be evaluated for the individual that they are and how they present to the clinic. And then with sufficient tracking, we can keep in mind, we can make sure that they progress through the pipeline well. So yeah, I think those are the two things that I'll add to that.
Okay. Thank you very much, Rini, for the interview. It has been a pleasure to listen to you and learn more about your research. So thank you very much for coming.
Thanks a lot, Javier. I really enjoyed this. I hope the best for your listeners, and I'm looking forward to talking more with you offline at some point.
We keep in touch, keep in contact. And to the audience, thank you very much for following the podcast. I hope you have enjoyed the interview, that you can transfer some of this information to clinical practice. And in any case, I hope that it has served to better understand the patients, the behavioral and motor capacities. And yeah, all of this is done for the patient by neurological explanation, neuroscience, clinical practice. All of this is for the patient. So thank you very much for listening. Thank you very much, Rini. Bye-bye.
Bye.